Good afternoon, ladies and gentlemen. Welcome to the webinar organized by the European Reference Kidney Network. The topic of today is methylmalonic acidemia, and it will be presented by two real experts in this disease and in general metabolic disorders, Professor Manuel Schiff and Dr. Anais Brassier. Both colleagues are very active in the metabolic ERN, and they are working in the reference center of inherited metabolic diseases in the Necker Hospital in Paris. This center has a large experience in methylmalonic acidemia. In Paris, I am very sorry. And historically, they were really the first one who had experience in combined liver kidney transplantation in this disorder, and they published large cohorts of patients in metabolic diseases and also in MMA. So my name is Elena Levchenko. I'm pediatric nephrologist in Leuven, Belgium, and I will moderate the webinar for you today. So as you all know, you can ask questions during the whole presentation, and we will try to answer your questions at the end of this webinar. So now I think all people are in, and I'm going to give her floor to Manuel and Anais to start the webinar. So we are really looking forward.
Thank you very much, Elena. Can you hear us well? I think so.
Yes, I can hear you perfectly. I will switch off my camera and then I will switch it on for the questions.
Thank you so much. So we are, like you said, two metabolic pediatricians in Paris, in Necker Hospital, and it's our pleasure to present today about kidney disease in MMA, methylmalonic acidemia. And it is true that in France, not all over the world, but in France, the first transplantations in this disease were performed in this hospital in our center. So we will start, we will divide the talk in three parts. The first one will be a general introduction of the subject. Then the second part will be a focus on kidney disease in this rare metabolic disease, MMA, methylmalonic acidemia. And the third part will be clinical examples, both from one single case report and also Reader Digest and summary of a publication where Anais was first author on the cohort of patients who were transplanted here, with some examples of the take-home messages, and then we will conclude the talk. So I will start, and in a few minutes, Anais will take over, and then I will speak at the end. So a brief introduction on methylmalonic acidemia. As you can see on the right-hand side, the story takes place inside the mitochondria. So you have the cell here, and you have the green part inside the cell, which is mitochondria, and you have products degradation, biochemical pathway of degradation of amino acids, which are valine, isoleucine, threonine, and methionine. And those amino acids goes into this succession of steps to be broken down into mitochondrial energy called ATP at the end. And in methylmalonic acidemia, you have a block in this step where methylmalonic-CoA cannot be transformed into succinyl-CoA. And in the twin sister of MMA, which is called PA, propionic acidemia, we won't speak about it today, but you should know this disease. It's the one step up MMA. And in this disease, PA, kidney disease is described, but less frequent than in MMA. So isolated methylmalonic MMA is part of the group of classic organic acidemia. And interestingly enough, for you and me, it's nice to diagnose this disease because you can measure the accumulation of MMA in urine and in blood mainly. And for those who are interested in inborn errors of metabolism, it's important to remember that we are talking about MMA without elevation of homocysteine, without low concentrations of methionine, because this points towards another group of disease related to vitamin B12 metabolism, which is not the scope of the talk of today. And like said earlier, in MMA, you have accumulation of MMA in urine and in body fluids. And in extremely rare, its overall incidence is 1 to 50,000 births. So in terms of metabolism, what are we talking about today? We're talking of a group of diseases here, where you have this black bar, which shows that you have an interruption in the degradation of amino acid to energy, and you have accumulation of organic acid. And these organic acid are accumulated inside the mitochondria and are potentially toxic for all for different organs, and among which kidney. So MMA is a genetic disorder. It's autosomal recessive disorder with different subtypes. You have the most prevalent, approximately 60% of these MMA are due to primary mutations in M-mut, which is the gene encoding for the apoenzyme called methylmalonyl-CoA mutase. So it's the gene is mutated, and then the enzyme methylmalonyl-CoA mutase doesn't work well, and you have accumulation of MMA. And among these subgroups, there's this group of mutation in MUT. You have two different phenotypes. You have the severe patients called MUT0 with no enzyme activity at all, and MUT minus with some residual activity. And usually in vitro, MUT0 cells do not respond to vitamin B12, while a few some of the MUT minus cells do respond in terms of enzyme activity to vitamin B12. And the second group of methylmalonic acidemia is the abnormalities in MMA A, which is called CBLA, and MMA B, which are called CBLB. So if you think about kidney disease, you should remember that it's mainly MUT patients and CBLB and CBLA. And if you go back to the general definition of an organic acidemia, so here is the breakdown of what we call branch chain amino acids, leucine, isoleucine, and valine. And you see that they all finish, this pathway finish up into the mitochondria of the production of succinyl-CoA and acetyl-CoA and further energy, ATP. And you have methylmalonyl-CoA mutase here, which is one of the last step of these pathway. And you can also see that you have at every step a known genetic disease. But we will not talk about all those red bars. We will focus on MMA, methylmalonyl-CoA mutase, or CBLA, CBLB. So we speak about inborn errors of intermediary metabolism with accumulation of toxic compounds with no consequence on embryo-fetal development, because the mother, I mean the placenta, is clearing the accumulated compound. Usually you have a symptom-free interval, which means that if you look at neonatal onset patients, they are normal at birth and they become sick after a few days with clinical signs of intoxication. This intoxication can be acute or chronic. You have provocative circumstances, catabolism, food intake, fever. This disease can be late in onset, so it's not all the time neonatal presentation and or intermittent. And like I said, the diagnosis is based on plasma and urine analysis, and most of them are treatable with, in acute setting, extracorporeal procedures, which is dialysis, or special low protein diet, because these guys, leucine, isoleucine, valine, they are compounds, amino acids, which are contained in proteins, and also some drugs that can get rid of the substances. So this is again general definitions. This is the general definition of an amino acid, which have an NH2 part and a carboxyl group here. And these amino acids can be measured in blood and urine with a technology called HPLC, or now more commonly by MSMS. And in the catabolism of amino acid, you will get rid of the amino group. This is measurable in blood. It's called ammonia, and you measure ammonia, and ammonia will be most of the time increased in MMA. And when you get rid of ammonia, you end up with a pure carboxyl group compound, which is called an organic acid. And MMA, methylmalonic acid, is one is an organic acid. Propionic acid is an organic acid. Lactic acid is an organic acid. Pyruvic acid also. So this is the general formula. And an interesting thing is that carnitine, which is depicted here, can link to the organic acid to form an acylcarnitine, an ester here. And this acylcarnitine can be measured in blood, and this is called the acylcarnitine profile. And it's interesting for those disorders because in MMA, you diagnose the patients either with the organic acid chromatography in urine or with the acylcarnitine profile in the blood. And as shown here, carnitine is an interesting drug, a cleaning drug, which can help getting rid of the accumulating organic acid. Okay. So Anais will take over with the clinical presentation of MMA patients.
Okay, onset of manifestation for MMA patients ranges from neonatal period to adulthood. And the most frequent form is the neonatal presentation. So infants are normal at birth and they develop rapidly lethargy and some vomiting and feeding troubles. And they develop neurological symptoms too, with hypotonia. And after a few hours or few days, they are in coma. So like said earlier, there is a short free interval. The most frequent is few days. There are other forms of the disease, late onset form, with different type of manifestation. Infants may have anorexia and failure to thrive. Other infants may have neurological presentation with developmental delay or acute neurological symptoms like basal ganglia stroke with some sequela or chronic neurological symptoms. And it's interesting to know that some infants can have protein aversion or vomiting with food containing protein. And there are some atypical phenotypes, not very frequent, most in CBLA or CBLB forms, with attenuated phenotypes or chronic renal failure. So it's important to keep in mind that in the neonatal presentation, there is an important risk of death despite aggressive treatment. This is a very severe disease, and and for all patients, there is a risk of metabolic decompensation, usually associated with intercurrent infection like fever or gastroenteritis, or other catabolic situation like surgery or other stress.
Avec la roulette.
So with the clinical presentation, we have some biomarkers to make the diagnosis. So first, as previously mentioned, you have acidosis. There is an elevation of MMA, and it's an acid. And we have hyperammonemia. That means ammonemia is above 100 micromole per liter for neonatal patients. We have sometimes neutropenia, thrombopenia, and anemia. We will see after that there is a toxic accumulation in bone marrow, and that is why there is sometimes neutropenia or thrombopenia, and it's possible to have hypocalcemia and lactic acidosis. So there are more to confirm the diagnosis. There are specialized tests. It's organic acid in plasma and in urine, and we have elevated MMA with normal B12 vitamin. And if you realize acylcarnitine profile, there is an elevated plasma concentration of C3, propionylcarnitine, which is, like said earlier, the step above this deficit. And there is another non-specific sign in plasma amino acid. There is hyperglycinemia. And during decompensation, we have to monitor the same biomarkers with plasma ammonia, blood gas, electrolytes, lactate, uric acid, ketone, amylase and lipase in case of digestive symptoms, and MMA in plasma and urine. And we have a marker of decompensation.
And just a small comment: the acidosis is always with a high anion gap. We could have noted that, we forgot, and it's a metabolic acidosis with high anion gap.
Sorry. So despite aggressive management, there are a lot of long-term complications, and most of them are very severe. Most frequent complications are neurological, in particular in patients with neonatal presentation with a variable intellectual disability. And it's frequent to have acute episodes during decompensation, like metabolic stroke, which can be responsible of movement disorder. The second important complication is progressive impairment of renal function. We will see after. And the physiopathology of this renal dysfunction is probably secondary mitochondrial dysfunction and the nephrotoxicity of MMA. Some patients develop acute or chronic pancreatitis, and some children may have growth failure This is frequent and probably multifactorial with protein malnutrition due to the diet and chronic acidosis and after chronic renal failure. As I mentioned, at the diagnosis or during decompensation, some patients have bone marrow failure due to toxic organic acids, and most of times this revert to normal after the decompensation. There are also sensorineural signs like optic nerve atrophy with acute visual loss, and this is most this complication is not in infants but in late onset. And there are some description of liver disease in publication with fibrosis, cirrhosis, and some cases of hepatoblastoma with unknown incidence. So for the management at the acute phase in neonatal period, we have to use hemofiltration or hemodialysis because of severe hyperammonemia and also for severe acidosis. Peritoneal dialysis is not used because it's less efficient. And for the conservative treatment, we have to take a high energy supply with intravenous glucose, lipids, and electrolytes. And in case of hyperammonemia, we have to use ammonia scavenger, in particular sodium benzoate in intravenous, and carbamyl glutamate that is more efficient than sodium benzoate. Of course, we have to stop protein intake during diagnosis and during decompensation. And in every patient, we have to try vitamin B12 supplementation because some patients can be responsive. For the long-term management, the principal goal, as you have probably understand, is to reduce the production of the toxic of methylmalonyl acidemia, and for that we have to make a very strict diet, and this is a low protein diet, around 1 gram per kilogram per day in early childhood, with an optimal calorie intake for the growth. And we have to supplement with carnitine, as previously mentioned, because carnitine can prevent, we have to prevent the carnitine depletion and to allow the expression of propionyl carnitine. Sometimes in some countries we can use antibiotics for the reduction of intestinal production of propionate and MMA. Some teams used special amino acid mixture without precursor, and of course we have to avoid prolonged fasting to reduce lipolysis, and the severe form of MMA patients have nocturnal tube feeding with gastrostomy or nasogastric tube. And so we have to avoid some circumstances of decompensation, like fasting or increased dietary protein. So the long-term dietary management is the key of the treatment. As already said, with low protein diet, we have to have a protein diet around 1 kilogram per day in early childhood. In severe forms, a lot of patients develop anorexia and feeding problems. This diet allows to reduce the accumulation of toxic metabolites, but we have to maintain nutritional status and preventing catabolism with a strict dietary monitoring, and we have to supplement with vitamin, minerals, and trace elements. So concerning the renal impairment in MMA, we say that this is an important complication in this disease, and all patients are at risk of developing renal insufficiency. As you can see on the right of the slide, chronic kidney disease is a significant clinical feature and is more frequent with age of patients, and is more frequent in the severe MUT0 and cobalamin B deficiency, and lower frequent and later in the MUT minus and cobalamin A deficiency. The principal kidney manifestations are chronic tubulointerstitial nephritis and renal tubular acidosis, and the evolution go to end-stage renal disease. And it's very frequent because it's around 65% in MUT patient and cobalamin B, and around 21% of patients in cobalamin A. And in a series of 30 French patients with cobalamin unresponsive MMA, 47% of patients develop chronic kidney disease at a median age of 6.5 years of age. Here we can see that age of chronic kidney disease differ between groups. It's more frequent and with
younger patients.
And in younger patients, for MUT0 patient around 8 years of age, like you can see in the graph here on right, and around 11 years of age in cobalamin A and 30 years of age in cobalamin B. And predictive factors of chronic kidney disease are age at onset, and the cobalamin responsiveness with frequency of chronic kidney disease lower in this group of patients. It's important to know that mean urinary MMA expression is correlated with the occurrence of chronic kidney disease, maybe with a threshold of 2,000 micromole per millimole of creatinine. And the deterioration of kidney function is often abrupt. How to assess renal function in MMA patients? At the beginning of the disease, signs of proximal or distal tubular dysfunction are common, and there are some cases of defect of urine concentration with polyuria and hypercalciuria. Some well-managed patients can have incomplete tubular proximal involvement with elevation of beta-2 microglobulinuria. The recommendation is to assess glomerular filtration rate with a measured clearance with Yoexol or inulin, because in this patient with decreased muscle mass and low protein diet, the creatinine and the estimated filtration rate are poorly predictive of kidney dysfunction. In some cases, we can use the cystatin C, which is independent of muscle mass, to estimate the glomerular filtration rate. And kidney biopsy is not necessary during the management. As previously mentioned, you can it's important to know that despite aggressive treatments, there is an important morbidity and mortality in this disease with long-term complication and metabolic decompensation, so poor quality of life. So this is why the transplantation, the organ transplantation is discussed, and this is kidney or liver or combined liver kidney transplantation can be discussed. This treatment can restore partial correction of mutase activity, and we can propose this transplantation to patients with frequent metabolic decompensation, difficult to be controlled, for patients with renal failure, of course, and for severe mut0 MMA patients before long-term complication as a preventative treatment. Which transplantation should be chosen? For severe MMA patients without renal impairment, we could propose early liver transplantation. For patients with MMA and renal impairment, we prefer a combined liver kidney transplantation. And for adult patients, we can discuss isolated kidney transplantation because it's a safer treatment option with less morbidity and mortality than liver transplant or combined liver kidney transplants. In general, in the publication, orthotopic liver transplant should be preferred to auxiliary liver transplants. And depending on countries, we can use cadaveric organs or living-related donors. Possibility of liver lobes from living relatives reduce waiting times, gives a result comparable to those obtained with cadaveric organs. And there is, in general, small risk of donors. And it's possible, it's not a contraindication to be heterozygote for the disease for living-related donor. So what are the expected benefits of transplantation compared to the classic management? In all publications, we see that there is a prevention of metabolic decompensation and decreased incidence of hospitalization, which improve quality of life. The growth may be improved in some infants. Cognitive function remains stable or improved. And in general, we can increase protein intake and, of course, correct the renal dysfunction. There are some complications, of course, of transplantation. Some are very rare and others more frequent. Vascular complications are rare. Rejection are globally frequent but treatable. There are some graft failure, infection. Neurological complication seems to be quite frequent in this disease, with focal myoclonus without encephalopathy, probably associated with anticalcinurin like tacrolimus, some seizure-like episodes, and transient and focal leukoencephalopathy. Other patients may present metabolic stroke and neurological toxicity of calcinurin inhibitors. There is, of course, the toxicity of anticalcinurin with renal impairments, and other complications are rare, like biliary complication or fibrosis that could be seen before and after transplantation. So dialysis for patients with renal impairment could be discussed. Principal indications are the persistent plasma MMA levels above 1,000 micromole per liter, despite optimal metabolic management. And there is a good correlation between measured glomerular filtration rate and mean plasma MMA. Some patient could be dialyzed because of chronic protein malnutrition with a risk of decompensation due to permanent catabolism. What is the place of newborn screening in this disease? It could be performed at day 3 with the measurement of C3 carnitine, that is the propionyl carnitine. With this technique, we can identify all causes of MMA, including vitamin B12 deficiency. But for the severe early onset form, maybe a result from newborn screening come too late when children have already developed symptoms of the disease. So we don't know the long-term outcome and the impact of newborn screening now because of the short duration of follow-up and the limited number of infants detected.
Okay, so we'll go on with a case report to show you how it's in real life, but it's exactly what Anais has told you, because you'll see this history of a first baby from consanguineous parents whose mother had normal pregnancy and delivery, and at birth the baby was basically normal, and he started to be not normal at the age of day 2. This is the free interval. After 2 days of life, he was polypneic, he was dehydrated, tachycardic, and he was, let's say, normal neurologically, but slowly becoming hypotonic. And when you did a workup on the labs of this patient, you would see hypernatremia, probably because he was dehydrated. But what was striking was the metabolic acidosis, severe metabolic acidosis. pH was 6.9. You had bicarbonate in blood at 3 millimole per liter, and if you could calculate the anion gap, it would be very high, and not explained by either ketosis or lactic acid. So you were with a anion gap with something else, and this something else was MMA, of course. So this baby was intubated, ventilated, and received bicarbonate infusion, and we all agree that this is possibly not very efficient, but in the neonatal care intensive care unit at that time they would do that, and he was transferred to intensive care, and he was basically in coma with this polypneic features, and if we had time we could show you some video where you see the baby in coma, very pale because of anemia, and sometimes abnormal movement, which can be like myoclonus but a little faster, which are not without abnormalities on the EEG. And this baby had no cardiac abnormalities, no infection, and he persistently had this metabolic acidosis with high anion gap. He had this hypocalcemia. He had also nothing on the red blood cells nor the white blood cell, but he could have had a neutropenia, and he had no infection. So then the diagnostic workup of this sick baby's newborn was sepsis, cardiac failure, renal failure, or metabolic disorders. And to support metabolic disease, he also had hyperammonemia. At that age, it's below 100, 80 to 100 micromole per liter. So he had quite a lot of accumulation of ammonia in his blood. He had normal lactate and ketonuria. And a newborn with ketonuria, it's not normal. So he was diagnosed with MMA. Like Anais said, he has high plasma glycine, high propionyl carnitine in blood, and MMA in very high amount in urines. So at the age of 3, then he was treated, he was dialyzed, he was acutely managed, like Anais told you, and then at the age of 3, he was seen at the clinic, and he was regularly followed with normal neurological exam. But he was also exhibiting numerous decompensations during the first years of life, including a few in the ICU because of the trigger of infections. And he was doing not too bad, except on the kidney part, because at the age of 6, in July 2011, he already had EGFR on cystatin C at 44. In 1 year later, 37, and a few months later, 32, and then abruptly, 3 months later, 19 milliliter per minute, 1.73 square meter. And when you would measure the GFR with the IXO, you would see that he also had a very low level. So he was, because of that, he had also accumulation of MMA in plasma very high, and you heard that MMA in plasma is a good correlation to the kidney function. And he had a low protein diet that could not be, amount of natural protein could not be increased, so he had very poor quality of life. He was very tired. He had hair loss, skin rash. So this is basically the scenario of those patients in whom you decide to go for dialysis. And the other part was because of high levels of plasma MMA. And since hemodialysis, he was less tired, he was more alert, and he had this improvement of the nutritional status both in skin and hair in parallel with increase in natural protein in the diet. And if you look at this table, you should maybe concentrate on the plasma MMA. And sorry if it's still in French, but we thought you would understand. So MMA in plasma here is the numbers are very high for, let's say, 4,000 micromole per liter, 8,000 micromole per liter, and then he was dialyzed starting here. And you see that before dialysis, before one session, he was 3,000, and then after 800, and then it was better here, 5,400, but it's still very high before dialysis. So he had a very severe disease. And then this kid was transplanted first. And before Anais takes over, I can just tell you the story that he was transplanted in 2012. And at that time, we had maybe a different view than the one we have now. He was transplanted in 2014. And at that time, we opted for an isolated kidney transplantation because he was very severe, and he was the kidney dysfunction was here, and that we expected that it would be enough in terms of enzyme activity brought by the transplanted kidney. But unfortunately, at the beginning, it was okay. He was doing well, improved quality of life, more protein. But then in the forthcoming years, and starting maybe 2018 or 19, seven years after the transplantation, his kidney function started to deteriorate, and now he's still dialyzed, and he's on the waiting list for a combined liver kidney transplantation, which roughly will occur 10 years after the previous one. So it's not a success, but it's not a total failure. But if we would have dealt with this kid now, we would have directly chosen liver kidney transplantation, because like Anais said, you have kidney dysfunction plus in a kid with MMA, and we would have chosen for isolated liver before the occurrence of kidney failure.
And it's just some results of a patient transplanted in our hospital, and it's published, and here it's for kidney transplant, and for liver kidney transplant we can see the result of plasma MMA before transplantation and after transplantation, with a real decrease for plasma MMA for kidney transplantation and liver kidney transplantation, and it's significant in urinary MMA before and after kidney transplant, with a tendency to re-increase after 5 years of follow-up for patients with kidney transplantation, and significant reduction of urinary MMA levels before and after liver kidney transplants. And for patients with just liver transplant, it's just about 5 patients. We can see here that the levels of plasma MMR are not very increased because these patients have no important renal dysfunction. So there is a little decrease of MMA plasma, but we have a significant reduction of urinary MMA after liver transplant, with a reduction to 2,000 micromole per millimole of creatinine, like you can see in this graph on the right. And concerning the diet, for all groups of patients with kidney transplant or combined or liver transplant, we can increase protein intake to 30 or 60 grams per day to 23 or 40 grams per day. It's more important with the combined transplantation. You can see the patient in yellow, and we can stop enteral nutrition in only 1 patient with kidney transplant, but in 7 to 8 patients with liver kidney transplants. So it seems to be most significant for patients with the combined liver kidney transplant in terms of increased protein intake and to stop enteral nutrition.
Okay, so to conclude, we've tried to show you an overview of kidney disease and MMA, and we hope you're convinced that it's a relatively frequent finding. Let's say 2/3 of the patients around 10 years of age, and remember this MMA mutase first CBLB and then more rarely in CBLA patients. Remember also that kidney deterioration can be abrupt, justifying a careful monitoring of kidney function in this disease. Increase of MMA plasma is a good biomarker, much more sensitive than serum creatinine, because low protein diet, low muscle mass. So creatinine is not a good biomarker. And before glomerular dysfunction, you have signs of tubular interstitial nephropathy with high uric acid in blood. And if you want red flags when to suspect that the patient is going to exhibit renal failure, it's when you cannot increase natural protein in the diet, the kid has protein malnutrition, more frequent metabolic decompensations, and of course, increase in plasma MMA. As you have seen, dialysis is indicated to improve both kidney function, but also, and more, let's say, even more importantly, metabolic status and plasma MMA clearance. And you've got some hints on different indications for liver as a liver transplantation as a preventative measure, and then the kidney transplantation in the adults with kidney dysfunction, and combined liver kidney transplantation in younger patients, children with already exhibiting kidney dysfunction, as a good solution in 2022 to treat those patients. And I think we've finished our talk. Thank you for your attention.
Thank you very much, Anais and Manuel. Really excellent presentation, and we see that we as pediatric nephrologists really need you as pediatric metabolic specialist and vice versa. It's a extremely severe but very interesting disorder where we really treat these patients together. The questions are coming, so please don't be shy and ask. I have already one question from my colleague Noel Knops in Leuven. So the question is, what is the effect of isolated liver transplantation on the kidney function? And can isolated liver transplantation prevent the deterioration of renal function in the long term?
Okay, it's maybe a little hard to respond because liver transplant, isolated liver transplant is realized only since maybe I don't know 5 years or maybe a little more. So we don't know exactly if it's possible to prevent renal deterioration, but we hope that the renal deterioration may be later.
The idea is to delay renal failure, but we are not sure it will prevent from its occurrence, because low protein diet is not a good treatment for those patients. And if you add liver transplant, we can hope that it will delay, but we don't know, like Anais said, the outcome, longer term outcome, because it's not, as a preventative treatment, it's not being performed for more than let's say 5 to 10 years.
Okay. Thank you. So there is another question from Jens Koenig. What is your opinion on citrate supplementation?
Citrate as an aplerotic treatment. I have no personal opinion. Maybe Anais has one. I must say we've not been using it for many years, and it's been used by our maybe predecessors. But I can answer that if it was really efficient, we would know it, and you would know it. So I'm not sure it's useful, but maybe in certain situations with extremely catabolic patients with difficult to manage, it could be useful for a few weeks. We don't know.
Okay, yeah, we also don't use it. So another question is, do you perform dialysis before the onset of end-stage kidney disease to stabilize the metabolic situation?
Yes, that's right. The most frequent case of dialysis is for the metabolic status. So in most cases, patients are not in end-stage chronic disease. It's because of very important elevation of MMA plasma level and for the nutritional status in general. Some patients can develop end-stage chronic renal failure, but it's not the principal reason for dialysis in this patient.
Yeah, and it's also something we try to discuss with you nephrologists, that we use the dialysis on the metabolic indication sometimes before the kidney failure indication. And also it's very important because in some instances we want to decrease the MMA in plasma to prevent, for instance, a neurological stroke or stroke-like episode. So it's very it's something that, and also it's you improve the amount of natural protein in the diet after you have started dialysis. So then when you decide when the kid is ready to be transplanted, the general condition is better, and the anesthesia, the risk of the procedure is lowered because he has more protein. There you have less sarcopenia, less side effects possibly of the transplant procedure. So it's a whole discussion. Of course, it's multidisciplinary discussion, and it's not just the metabolic physician who says, I'm going to dialyze you. It's you, us, and all the people who, intensive care people, surgeons, and you know that better than us. But it's important discussions which sometimes not everybody agrees, but we try to end up with a consensus on every child, and it's individualized, personalized medicine, and so on.
Yeah, sure. Just an announcement for everybody. Apparently, some people cannot see the question tab. So if it is like this for you, you can just write your questions in the chat, and then we will answer them. Because some people mentioned that they cannot see the question box. So in the meantime, I have another question. What kinds of the perioperative protocol do you follow to prevent metabolic decompensation during transplantation? And another question, do you propose to reduce the dose of corticosteroids and or CNI? So one question is about the perioperative protocol, and the other about the dose of steroids and CNI in those patients.
So the perioperative protocol is also individualized to every situation, but as a general answer, we want to prevent metabolic decompensation. So let's say if the patient has a kidney failure, is dialyzed and comes during the day, you can discuss with nephrology whether, or intensive care unit, whether they have the possibility to dialyze the patient when he or she comes for transplant, because it's going to be probably a good way of lowering the MMA in plasma. That is first. Second, you have the IV infusion of you stop the diet, the protein in diet, and you have IV infusion of glucose, electrolytes, intralipids. Not for you don't want to use intralipids when you go for combined liver kidney. You can have it if you go for kidney alone, I think. Yes. And basically we noticed that the amount of glucose is too high in the infusions we were used to prescribe, because it often the patients end up in hyperglycemia and hyperlactatemia. So we tend to decrease this to lower the glucose infusion rate. And the most important thing is that the patient has to be in good condition, good nutritional status, not sick, no fever, of course. And the third question was about the anti-calcium.
And just we monitor lactic acid and ammonemia and electrolytes during the procedure. Yes.
Okay. And would you recommend to dialyze a patient, for example, between the liver and the kidney transplantation in the operating theater, or you never do that?
Entre les deux, entre le foie et la transplantation du foie, transplantation, non, on n'a jamais fait ça. Non, the only thing we have done is the pre-operative transplantation.
Okay.
And regarding corticosteroids, I don't think there is a specific protocol for those patients. It's true that it's potentially a trigger for decompensation, but we've never seen, I think, and transplant team did not notice more side effects related to corticosteroids. On the other hand, we are at the moment with others, European colleagues, thinking about what you've heard and you mentioned is the toxicity of anti-calcineurin drugs, especially on stroke-like and brain toxicity in MMA, NPA, but more MMA.
And renal toxicity.
And also renal toxicity. So we are discussing with the kidney doctors, liver doctors, surgeon to change a little bit the immunosuppression protocol.
Okay, but at this moment you are using the standard immunosuppressive protocol, if I understand correctly. Is it right? So are you using the standard immunosuppressive protocol? Yeah. Are you using the standard protocol for liver kidney transplantation here?
For liver kidney, I think we are about to use cyclosporine more than tacrolimus because of that.
Okay. Yeah, I see. I think it's so big discussion field. We always have discussion with our metabolic physician, for example, if the patient has an acute rejection, can we use the high dose of steroids because it's a risk factor for the metabolic decompensation?
Yeah,
Then it
but this is not, I think we can answer that. It's not a problem. You can go for a high dose of steroids, especially after transplant, because he's been
After transplant, there is no risk of metabolic decompensation, or
okay.
it's not a problem.
Very good. So I see at the time, maybe one question from myself. If you dialyze on those patients, what is your dialysis regimen? How many times per week do you dialyze? How many hours?
With hemodialysis, that is a question?
Yeah.
Okay. Here, I don't know if it's the same in all centers of dialysis. It's 4 hours, I think, of hemodialysis. But, I am not the specialist of dialysis, sorry.
Okay, but also nothing.
4 hours. Yes.
And in the most severe patients, they can go 6 days out of 7.
Yes. It's 5 or 6 days.
Okay, so you dialyze more than 3 times per week, so you
Yes.
Okay.
The day without dialysis, we reduce the protein intake for patients because of high level of MMR.
Okay, very good. Okay, very nice. So as you know, there is now the guideline or the clinical practice recommendation on MMA. It's a joint venture between ERKNet and ERN. So I think it will be a very useful document to put some guidance on the treatment of these very rare and severe patients. So I'm really looking forward to that. I'm checking if we have any other questions. I don't think so. So once again, thank you very much for this wonderful webinar. The webinar is recorded, so people can watch it again on the website. Thanks again, and a lot of success with those patients, sir. Bye-bye.
Thank you for inviting us. Thank you. Bye-bye.
Bye.
Bye.
Thank you. Bye.
Thank you.